Okay, so now we're going to talk about antianginals. Don't be intimidated. We've already done this column here, these columns here, now we're here. And for antianginals, we have beta block, calcium channel blockers, nitrates, and then a miscellaneous drug. We've already talked about the beta blockers and the calcium channel blockers. We are going to talk about them again, but just remember that these are drugs, probably 6 or 7 drugs we've already talked about in previous videos. So there's more information that they also fit into another category, which is an antihypertensive, but they are angina. So let's get started. This is we're not going to nitrate. So the beta blockers we're going to talk about are atenol, metoprolol, and propranolol. We've already talked about these drugs. We talked about them over here. We were talking about hypertension. Remember, they all end in LOL. Beta blockers. We talk about them again over here. Similar information, pretty simple. Okay, they are for angina. They want to stop angina. Antianginals. They work by blocking beta-1 receptors on the heart, which leads to AV conduction depressed, which decreases cardiac output, which decreases blood pressure, which leads to decreased heart rate. So the myocardial O2 demand decreases, and it also increases the oxygen delivery to the heart. It can also lead to decreased myocardial contractility, which helps conserve energy and decreases demand. So I'm going to put that over here. Please pause it if this helps you. Blocks beta-1 receptors on the heart. The AV conduction depresses, which decreases cardiac output, decreases blood pressure. It's also going to decrease heart rate, so it decreases myocardial O2 demand, which increases O2 delivery to the heart. And it's also going to decrease myocardial contractility, which helps conserve energy and decreases demand. So, I said that right. It's slowing the heart rate. Think of beta blockers as just slowing things down. So for these drugs, there are some nursing implications. A pulse rate less than 60 and any dyspnea to their doctor. They also need to not drink alcohol, not get in hot tubs, and they should journal their angina attacks. So they need to say like Tuesday, March 5th, I was cutting the grass. It was really hot outside, and I started experiencing chest pain. I went inside and I sat down, and the chest pain stopped after 3 minutes or whatever. They need to write down like kind of what triggered it, what was going on, if it was hot outside, or if it was just like the specifics of the situation as to what triggered the angina attack. So those are the blockers. We did talk about them already, so don't be freaking out that there needs to be a whole other drugs that you need to learn. We've already learned them. It's just remembering that they can also be used for angina or hypertension. So another category we've already talked about, channel over here. This was for angina and hypertension, but now we're going to specifically talk about angina, as this is the anti-anginal video. So these are the drugs. I'm not going to say them correctly, but here we go. Verapamil, diltiazem, nifedipine. That sounded bad. And amlodipine. Ooh, that sounded bad. They're the drug names. Channel blockers. They work by relaxing peripheral arteries, decreasing afterload, which the pressure of the left ventricle must overcome, decreases tension, and decreases oxygen demand. This can be used for chronic stable angina, which is for patients who can't tolerate beta blockers or nitrates. It can also be used for coronary artery spasms or Prinzmetal angina. There are some nursing implications. The patient needs to report blood, edema, weight gain of more than 2 pounds in a day or 5 pounds in a day. Actually, that's really bad. Head, eye, mouth fainting, and dyspnea. Patient also should avoid alcohol, hot tubs, and journal those angina attacks. This is a new category. It's nitrates. We talked earlier, and we'll get into that in just a second, but we briefly talked about it. So the drugs here are nitroglycerin, isocitrate, and isosaccharide mononitrate. That's how you spell them. Isodor Dilatrate tests are under mono. So the classification here is a nitrate. It is an anti-anginal. They can be used for the treatment and the prevention of angina attacks. The treatment, these are going to be acting. They're going to go under the tongue, or they can also be isosorbate, nitroglycerin. So the IV can also be used for hypertension with myocardial infarction and hypertensive emergencies, but that's just when it's given IV in the hospital, not like the little pills that go under your tongue. So this works by vasodilating the smooth muscles. So this decreases the oxygen demand and the cardiac oxygen demand. That's how it works. The adverse effects are headaches because of the dilation of the cerebral blood vessels. So this means that the patient can take it with aspirin or Tylenol to help decrease the likelihood of those headaches. These headaches do diminish usually with the continued use of the drug. Reflex tachycardia, because it's in response to the decreased blood pressure by the because of the baroreceptors. It can also lead to postural hypotension, and that patient may develop tolerance, so they need to start with a small dose and take drug holidays. And the drug tolerance can develop in as little as 24 hours. The nursing, a teaching point is that for sublingual, there can be a burning sensation. That just means that the drug is still potent. So you can tell your patient, like, hey, here's your little bottle of pills. You take this if you start feeling chest pain. You sit down, you take this, and it's going to burn a little bit under your tongue. That's okay. It means it's working. It's still potent. It's still going to work in your body. So you can just tell them that in 1 to 3 minutes, especially when it's under the tongue. So there are some special things about nitroglycerin and these other drugs, isosorbide dinitrate and isosorbide mononitrate. There are some special little things to know about the storing and administering this drug. So listen up. Okay, storing, they have to be in special non-PVC tubes and bags or a dark bottle. This is because sunlight can affect the potency of the drug. They come in several different forms that are chewable or oral. They also come in drugs that bypass the first pass effect, so they don't have to go through the liver. This can include sublingual, buccal, sorry, I always say buccal, IV, transdermal patches, ointments, and translingual spray. So those are a whole bunch of different options that can really get the medicine into the body quickly. Typically, they say that if the patient has angina pain, like let's say I'm cutting the grass and I start experiencing chest pain, I need to stop my activity, take a pill, and sit down. You really want your patient to sit down just in case they have a sudden decrease in blood pressure really, really quickly. You don't want your patient to fall and hit their head, because then you got a whole other host of issues that you got to deal with. So have your patient stop your activity, sit down, and take a pill. If 5 minutes go by and there's still more pain, the patient should take another pill and call 911. Do not drive to the hospital. Call 911. Please stress this to your patients. Don't have them drive to the hospital, because then they could end up causing a wreck or crashing into something, or just it would not be good. You don't want them to be behind a wheel and possibly hurt them or hurt somebody else. So call 911. So here we've taken our first pill. We've waited 5 minutes. There's more pain. Take another pill. Call 911. Wait another 5 minutes. Over here, 911 is getting to your house, so they should be there quick anyway. If after 5 minutes after you've called 911, after you've taken that second pill and called 911, if you're still experiencing pain, take another pill. That's it. So you have chest pain, stop your activity, sit down, take a pill. Wait 5 minutes, still have chest pain, take another pill, call 911. Just hang out, wait till 911 gets there. 5 minutes go by, you still have chest pain, take another pill. By then, hopefully 911 should be there. If not, just don't drive to the hospital and sit down when you're taking your medicine. So there should be something to note that isosorbide dinitrate is metabolized into the liver and it turns into isosorbide mononitrate. We're probably not going to be tested on that, but it's just knowing that this drug, the dinitrate, turns into the mononitrate once it goes through the liver. Patients should also not drink alcohol and not get into hot tubs. They need to journal their angina attacks just like the other drugs, and usually the potency decreases on the drugs 3 months after the bottle has been opened. So you don't want somebody to like, oh, let me just pull out a bottle from my cabinet and take one, because you don't know how old that drug is. And you also typically want your patient to keep the drug like on their person, because it's like, oh, I'm having chest pain, let me run inside and go get my nitroglycerin. No, you want them to be able to say, oh, here it is. This is my whiteout. Here's my medicine. Let me take one real quick after I sit down. That's just what you'd want them to do. So those are the anti-angina drugs that we know how they work. There's one more drug that we're not exactly sure how it works, but it is an anti-anginal. The drug name is Ranzaline or Ranexa. It is a miscellaneous anti-anginal. And the way that it works is it's kind of unknown. It does not involve decreasing the heart rate or decreasing the blood pressure, but it does prolong the QT interval, which allows more time for the heart to recover. And it also reduces the accumulation of sodium and calcium in the cardiac cells. So again, this is that drug, Ranzaline, that we're not positive how it works. It does not decrease the heart rate. It does not decrease the blood pressure, but it does prolong that QT interval. So your heart has a little bit more time to like catch up and like recover between beats. So this drug, patient's not getting relief from other anti-anginal medicines. Typically, they're going to go with one of the other ones that they know how it works before they give them this drug. But you could still see somebody on this drug. I'm pretty sure our teacher said that she's never actually seen a patient on this drug while she was working in the hospital. So there are some adverse effects: hypertension, constipation, nausea, vomiting, a prolonged QT interval, and heart attack. There are some nursing implications. You need to assess your patient for any EKG abnormalities and liver dysfunction. The patient should report any blurred vision, dry mouth, fainting, or dyspnea to their doctor. They need to avoid alcohol and hot tubs, and again, journal their angina attacks. So those are all our angina drugs. Remember, there are some drugs that kind of crossed over into the antidysrhythmics. No, not antidysrhythmics, antihypertensions. But it's just knowing that these drugs can work in both categories. It's the same drug, but they can do many things. So I hope this helps.